Amy Pepin is a senior consultant with CHI-JSI. She has an extensive experience in substance use disorders prevention and treatment, policy analysis, program development, and best practices implementation. Amy has earned her master's in social work from Boston College and her bachelor's in social work from the University of New Hampshire. Amy was the 2013 recipient of the NH Alcohol and Other Drug Counselors Lifetime Achievement Award and is a past president of the New Hampshire Alcohol and Drug Service Providers Association. And we just want to thank Amy again for presenting this webinar today. Amy, if you're ready, I can hand things over to you.
And thought it might be helpful to orient folks to New Hampshire a little bit. Come on, next slide. There we go. I'm figuring it out. So beautiful New Hampshire is all the way up in New England. We're in between Maine and Vermont and on top of Massachusetts, which are the New England states that you've probably heard of before. We've got all of the kinds of climate and all of the kinds of outdoor recreation that anyone could ever want. We've got ocean, we've got lakes, we've got mountains, we've got forests and fields, and you name it. It's a pretty beautiful place to live, especially this time of year. A lovely shot from what we refer to as our lakes region, and a beautiful photo from the mountains. These flowers will start blooming within the next month or so, and they're actually quite lovely. However, we know in New Hampshire we have some of the most significant alcohol and drug problems in the country. And because of that, almost 20 years ago now, legislation enacted a Governor's Commission on Alcohol and Other Drug Misuse, tasked with planning for and dealing with alcohol and drug problems in New Hampshire. We here at JSI, through our Center for Excellence, which I direct, have been fortunate to be involved with the Commission and involved with that planning, and are in the process right now of updating our strategic plan. And I say all of that because it's very important as a catalyst to how we got to SBIRT. In the plan that we are wrapping up right now, planning which started in 2012, SBIRT was identified as one of the key potential strategies. It was a potential strategy because no one in the state was doing it, and because we didn't really see any way that anybody would be doing it. We had no resources to put towards such a thing or any plan to get any. But that's the beauty of doing strategic planning and making sure that you include things that make a lot of sense, but you're not sure how you're going to get there yet, because we have the great good fortune in New Hampshire to have our New Hampshire Charitable Foundation be integrally involved with these kinds of efforts. And in fact, they financially supported the creation of this plan and support technical assistance to the Commission, which we here in JSI's New Hampshire office provide. So through that relationship with the Charitable Foundation and the Foundation's understanding that SBIRT was a key strategy that the state wanted to see implemented, the Foundation was able to develop a relationship with the Conrad Hilton Foundation. Hilton Foundation was 3 years ago initiating a new initiative in their youth prevention portfolio, which focused around SBIRT and youth SBIRT in particular. And the Charitable Foundation partnered with us to craft a proposal, and then very fortunately engaged us to do work that came from that funding. So New Hampshire has had funding from the Hilton Foundation for the last 3 years in partnership with the Charitable Foundation. The project has 3 arms to it. Training and technical assistance, which we do here at the Center for Excellence in the New Hampshire JSI office. An advocacy arm, which our colleagues at New Futures do here in the state of New Hampshire. And of course, provider partners who are the implementers across the state. The goal of the project is the universal adoption of SBIRT for all New Hampshire youth. And we set out to screen no less than 10,000 patients by this year, and we have actually met that goal, which is very, very exciting. And I'll tell you more about that in a few minutes. So before we can really talk about our project, we need to be able to set the baseline for what we're talking about when we talk about SBIRT. What we know to be true is that depending what state you are, depending what setting you're in, depending what training people have had or what other information they've been privy to, SBIRT means different things to different people. At its baseline, we're talking about a process over time. We're talking about universal screening, brief intervention, and referral to treatment. Here in New Hampshire, we really came to a concept which we've even visualized as a circular process to reinforce the notion that SBIRT is a process over time, and it's not an event, and it's really not about screening. Screening is a small component. So let's talk a little bit about exactly what we're talking about in New Hampshire when we're talking about SBIRT. Because SBIRT is a process, because it contains these different components, it makes perfect sense that folks would describe it differently and would implement it differently in different places. In New Hampshire, this is where we've landed with the primary care, with the help of the primary care practices that we've been implementing with. The screening tools, we set out to use an evidence-based screening tool that would be appropriate for all youth. We're talking about youth from ages 12 to 22. The CRAFT was that tool until quite literally within the month of our implementation. Dr. Sharon Levy down at Boston Children's published around the tool that they had been researching and working on, S2BI. She was a partner on our project and a technical consultant, thank goodness, an expert consultant for us, and was able to really explain and train around S2BI for us right out of the gate before a lot of other people had access to it. So we were able to have the flexibility in our implementation to encourage people to use either S2BI or CRAFT. We really encourage people, if they're starting from scratch, to use S2BI because it's much simpler and more straightforward. But lots and lots of folks, particularly pediatric sites and other sites that regularly were already screening, were very familiar and comfortable with the CRAFT. So we certainly didn't want to undo systems that were already in place unless that was something that the site was interested in. So all of our sites are using either S2BI or the CRAFT. When we're talking about brief intervention, we are talking about a short, motivating conversation that happens in response to the screening results in real time in the course of that visit when the screening happens. And we are talking about short. We started off training, and it says here 3 to 7 minutes. I think 7 minutes would be considered long by our providers, and really we're talking about more like 2 to 4 minutes is probably the kind of conversations that they're having, which they're finding to be very rewarding and are actually enjoying quite a bit, which is a very helpful and positive finding for us. We're talking about using motivational interviewing techniques, not being an MI expert. We train to the spirit of MI. You may have heard that phrase. Not to be motivational interviewing experts. And we encourage sites to create a flow where these conversations are happening with the primary care providers and the young person. That hasn't happened at every site, but it has happened at most of them. And we've had some sites that started with a different flow and then actually moved to this because it worked better, and we'll talk about that a little bit later, which is how we came to that recommendation. We train and remind sites that the brief intervention very much is patient-centered. It's very much dependent on the patient's circumstances and preferences, and that brief intervention is about asking for permission and listening as much as it's about trying to motivate change, that engaging that young person around having a conversation with someone that is open to hearing them talk about this subject of alcohol and drugs is in and of itself very helpful. And we have heard that testimony from practitioners now over and over again, and have some nice vignettes of folks telling us stories where they were able to engage patients in conversations that that they never knew before that they needed to have. So listening is important, and we really conceptualize brief intervention as little conversations over time. Most of these conversations are not about referral to treatment because, as you'll see later in the data, it is a very small percentage of young people who screen as requiring a referral to treatment. So most of these conversations are about reducing or eliminating risky behavior. It's about the practitioner or other caring adult being able to express their concern about the behavior and be able to again, open up a dialogue to have this conversation over time. The other thing is for young people who indicate that they have some use behavior, but it doesn't rise to a moderate risk level, that really it's about brief advice. It's really about the practitioner taking a couple minutes to say, hey, is it okay if we talk? Thanks for filling that out. Is it okay if we talk about this? You know, gee golly, I see that you're, looks like you've had some drinks in the past year. Can you tell me a little bit more about that? And they talk about drinking on 4th of July or New Year's Eve or Cinco de Mayo or whatever the case may be. But it's not a pattern over time. It's not something that probably would ever risen to the level of anyone talking to them about it, except that you have a wonderful tool that has identified that they've had some alcohol use in the last year. So you're not going to ignore that. That's a risky behavior. It is not a healthy behavior for a child, but on the other hand, you don't have to dive in deep to it. So practitioners can just do brief advice where they say, and are able to just talk about that they're concerned about that behavior, that any alcohol use is not healthy for a young person, and that they would really advise that that's not something that the young person continues to do over time. It opens the door and is very non-judgmental and is all about the health and the health behavior, because that's what this is about. The single big barrier that we hear that I'm sure you've all heard or struggle with around SBIRT implementation, the first thing that we hear is we can't possibly do that. We can't screen for alcohol and drug problems because what if we find one? There's nowhere to send kids for treatment. In New Hampshire, that is very real. We don't have an adolescent treatment system per se. We have scattered outpatient providers. We have very few, and by that I mean 1 or 2 intensive outpatient providers, and we have no inpatient providers of specialty alcohol and drug services. So it is a very real thing to be concerned about referral to treatment. What we have found, however, acknowledging that right up front and saying, yeah, you're absolutely right, that could be a problem. What we have found is 2 things. One is that we here at JSI, through our Center for Excellence, through our contract with the Department of Health and Human Services, we're able to develop and run a treatment locator for the state of New Hampshire. One of the domains is that it identifies folks who work with adolescents, and that is a tool that most primary care sites simply weren't aware of, especially pediatric sites, because they were not identifying very many people in need of alcohol and drug services, and simultaneously they believed that there weren't any, and so they didn't look for them. So one of the things we've been able to do is really expose sites to the treatment locator, which has allowed sites to connect with outpatient providers in their area and make those treatment relationships. It's also true that a number of the sites that we work with have internal behavioral health capacity, or in at least one case, developed internal behavioral health capacity as a result of this project, which is very exciting to see, and we think we're going to start seeing more of that. This is always my reminder to say SBIRT ends in RT. Of course, that stands for referral to treatment, but what it really is referral to assessment. Screening is not diagnosis. Screening indicates a potential problem. It doesn't indicate a diagnosis or disorder, and that it really takes a trained behavioral health diagnostician to both diagnose the substance use disorder and whether it's mild, moderate, or severe, and also to do the treatment planning to ensure that that young person gets to the right level of care. And the reality of that through this project has really reinforced what our premise was at the beginning, which was there just are not a whole bunch of kids who require who either are screening with acute levels of use or requiring residential levels of care, which is what people think of when they think about treatment. So when we talk about a project like SBIRT, one of the kerfuffles that we get ourselves into is that we're talking about screening, brief intervention, referral to treatment. What people hear is screening and referral to rehab. And in a state that doesn't have that, it makes it seem impossible to implement such a thing. So one of the things that we really do a lot of is talking about screening is not diagnosis. A brief intervention is just a conversation. It's not therapy, and it's not long. And a referral to treatment is really a referral for further assessment, diagnosis, and treatment planning, and moves that person to specialty care in much the same way they would do if a potential cardiac problem was identified, and they referred to the cardiologist. They wouldn't refer with a diagnosis. They would refer with a, gee golly, we noticed this, and it seems like something you might want to deal with. And that's exactly what they're doing in this situation as well, which is what primary care is really good at. And if you frame it that way, it makes tons of sense to them that that would be their role. So the key piece that is not part of the acronym, but really reinforces and aligns with the notion of SBIRT as a process over time is follow-up. You can't close the loop without follow-up. So, and we walk folks through the notion that they screen, and the young person screens positive for some marijuana use, let's say, in the past year. And their practitioner does a fantastic job having a very open conversation with them and asking them questions and eliciting some change talk from them and getting them to agree that they're going to cut down on their, you know, twice a month marijuana use to once a month marijuana use. And that is great and wonderful, and that is a huge win. And that practitioner feels fantastic after that. The kid's feeling good, like I made a positive change. My doctor, you know, made a lot of sense to me, and I actually like them, and they care about me. And then what happens if they never, ever, ever get asked about that again? It undoes it. It undoes the potential positive change. Follow-up is critically important. So one thing that we learned, one thing that I learned, my background is in social work and with youth services, one thing that I learned is that when you say follow-up in primary care, they start wanting to schedule appointments. And while that may be exactly what is needed for some cases, it's probably not what is needed for all cases. So we have been able to have some very wonderful and creative conversations with primary care sites about how do you follow up with young people to simply check in to say, hey, I'm thinking about you. We had this conversation about this very important thing, and we talked about how potentially dangerous it can be. And because we all care about you here and don't want you making dangerous choices, we're going to follow up and see how you're doing with that. You know, you said you were going to make some changes. How's it going? And how, again, can we help further? So we've had some sites that have gotten releases with young people to be able to text them on their cell phones to check in. We have at least one or two F2HCs that are doing telephone follow-up, and we certainly have sites that are scheduling follow-up appointments, particularly to continue this conversation, especially when the practitioner doesn't feel like they have enough time in the room to really have a good conversation, or if they feel like it is risky enough behavior that they want to see that kid again face-to-face to see what's going on. So we can't say enough about follow-up. Follow-up is really the whole thing. If you screen and it's negative, you're going to have some positive reinforcement. Good job, 14-year-old boy with the not drinking. You know, most people your age don't, so it's terrific that you're not. It's really a very healthy choice for you. And then the follow-up would be at the annual screening in the next year. The standard of practice that all the sites have agreed to is that they're going to screen at least once per year. And most sites are scheduling that at the annual physical or well child visit or whatever they call that visit. But they're also finding that not all of their patients come in every year for a physical visit. And so they're having to get creative about having a reminder list to ensure that they are following up by screening again the next year. Brief intervention, that follow-up, again, that can be telephonic or by text or face-to-face, and really at the in a time frame that makes the most sense for that practice, that practitioner, and that particular patient. And we have had folks that have told us it felt that they would have been uncomfortable not seeing that young person again the next week. And then we certainly have ones that are scheduling follow-ups like 3 months out, which is just a check-in touch point to say, yeah, you know, remember we talked about that? We just wanted to see how you were doing. And then, of course, with referral to treatment, that's the one that's the most straightforward, and that's the one that people think about most clearly around having a follow-up. But that's actually the one that tends to be more cumbersome to follow up because it's not all under the primary care's control. And it requires relationship with the other organization, and is one of the reasons, one of the many reasons, that we strongly recommend them engaging in some relationship building and memorandum of understanding up front with potential referral sources, so that there's a more seamless follow-up mechanism in place, and so that the provider will get information to know whether or not their patient ever wound up having the care that they referred them for. Okay, so that's really your baseline. We haven't even started yet. Just kidding. So, to talk about the implementation and really talk about our role providing training and technical assistance, we embarked on creating an action learning collaborative with our first cohort of grantees. Sites were invited to apply. Any primary care site that served young people 12 to 22 were invited to apply to receive some funding, and it was a significant amount of funding, and to be part of the Learning to Collaborative, to receive training and technical assistance, and to really be part of this learning nationally through this project for the Hilton Foundation, and aggregating our learning across states to try to really come up with recommendations around how to do this and what it can look like for primary care sites. So the call went out, and we didn't get a lot of response. We got 5 responses in the entire state of New Hampshire, 5. And we were like, whoa. So we dove into that a little bit. The barrier that we heard was really about learning collaborative and about time and energy for a new change project. That sites were very much overwhelmed and overloaded with change process. We are a state, as so many are, that recently had a number of changes through healthcare reform that have been, as it pertains to alcohol and drug access to treatment, have been very positive, but they have been cumbersome for sites, and there's been no small amount of disruption in the healthcare system. So it was right in the midst of all of that that we're coming to them and saying, yeah, but don't you want to do this? Come on, let's learn together. And they're looking at us like, you guys are nuts. But we got 5 takers, and we were pretty excited about that. And so we said, fine, you know, we'll start with 5 takers. Offered them, they all agreed to be part of the Learning Collaborative. They agreed to monthly phone calls, to regular meetings to sharing learning cross-site, to sharing data with us, with the Charitable Foundation and with the Hilton Foundation, and data collection, you know, certainly turned out to be cumbersome and time-consuming, but that is, of course, one of the reasons that there was some significant dollars available to them. The Learning Collaborative was meant to develop resources and develop lessons learned over time. We started out with very much a sense of we're all going to learn how to do this together. We here at JSI had certainly looked into and researched and immersed ourselves in everything SBIRT that we could find from across the country, particularly as it related to youth. But what we knew and the purpose of Hilton's funding was that there wasn't at that time really good implementation resources directed at adolescent implementation. So, so we went into it with wide open, you know, hey, try this and tell us if it works or not. We're very fortunate that we had sites that were very forthcoming with feedback and willing to share with each other and with us and then with other folks in the state. So in the subsequent years, we were able to onboard more organizations in great part because our first year, well, each year we have had what we call the SBIRT Summit in the fall. And at that summit, grantees have generously donated their time and experience on a panel to really get up and talk about what they've been doing and what's working and what's not working and what their experience has been, and universally to recommend to other sites that they implement SBIRT. We certainly haven't had any sites that have said, geez, you know, now that we're not going to get funding anymore, we're not going to keep doing this. We haven't had any of that. And so that's been exciting, and in and of itself is a good outcome, I think. What we do have is many of them out banging the drum to say that everyone should be doing this, and that's really very exciting, including now developing champions at sites in some of the biggest healthcare organizations in our state that are banging the drum in their organization that not just should this be happening in every pediatric site, but it should be happening in every primary care site. So that is exciting, and is in some, at least small part, as a result of our Learning Collaborative. Our scope of training and technical assistance, of course, as I just said, includes the Learning Collaborative, but was much broader than that. Webinars not just for Learning Collaborative members, but more broadly than that. Teleconferences, as I said, on-site training, on-site consultation, phone consultation. We did facilitation of quality planning and quality improvement. We've done presentations of every kind, including one like this today, all over the country and all over the state. We have the summit that I just referenced, and our two really big endeavors in terms of ongoing technical assistance is the creation of the New Hampshire Playbook and our website, sbirtnh.org. So if the universe is nice to me, I'm going to be able to click through and share. Nope, hold on. I know how to do it another way. So this is our website, sbirtnh.org. We regularly update information here. It contains all of the research and learning that we have developed, but also our aggregation of key national resources, shortcuts to those. So this is really a place in New Hampshire that anybody that's interested in SBIRT can come to. And if we don't have what you want, you'll be able to click through and find it to sites like ARETA's site nationally and the other key resources that are available nationally. I want to take a minute to show you our playbook electronically. The playbook is here electronically. We also have a print version, and you can request a hard copy. You can download the playbook. You can, of course, preview and review it electronically. It is made up of 3 sections. And we have developed it this way and in this order as, again, as a result of 3 years of learning and growing through this implementation with all of the implementation sites. We conceive it as a playbook because what we know from working so intimately with such diverse practice settings is that different ones are going to need to lean in different places. And this allows them to do this decision-making process in the order that makes the most sense for them. But we do recommend that every site really needs all 15 plays. The first section is about beginning practice change, and we're going to lean in around forming a team in a minute. The next is really about preparation and reviews, screening, brief intervention, referral to treatment, and follow-up in depth as I just did with you. The key play here is confidentiality, and we're going to lean into that in a minute as well. Also flow and electronic health records that we're going to talk about more in depth. The final section we called success and sustainability, really to ensure ongoing data collection is used for quality improvement, that billing and reimbursement and coding issues are thought about in an ongoing way throughout the process. We're going to lean in there as well. Communication around SBIRT implementation is a really important and interesting play to look at. And then our play around training, which in the nutshell says train, train, train some more, and then offer some other training, and then train again in another way at another time. So importantly, in this iteration of the playbook that just came out this fall, we added reflection and celebration because we found that, as we all do, we plan for something, we get to doing it, we're like, okay, good, check that off the list, and then move on to the next thing. And what we saw was, because we were involved and invested with sites over time, we saw some of them that were doing really great stuff, and they didn't really note it and hadn't stopped to say, wow, team, remember all those meetings we had last year? This is what the result of them was. This is really important stuff we did. So to be able to really stop and reflect on the successes in their implementation and not just always be looking for what's not working right. So if I can get back to my, yay, that worked, okay. So I just want to, we're going to lean in a couple of places. This is our implementation checklist. It is one of the first page is up front in the playbook. It runs through all the plays on one piece of paper and just basically lets sites be able to keep track of where they're at with things. As I said, we're going to talk about team, confidentiality, flow, EHR, billing and reimbursement, and training. And then this slide says the same thing. So what we have learned, what we believed to be true, and know from both experience and from the literature is that that implementation requires quality planning and quality improvement processes, and that a team to do that is the best possible way to do it in healthcare sites. And so we recommended that right up front and did training around doing that. We asked sites to identify their teams in their application from the get-go so that it was really understood that that was part of the expectation. We asked teams to come to learning collaborative meetings. We asked teams to be on phone calls. We reinforced team. So as you might expect me to be saying, some sites had teams and some sites really didn't. And what we saw and what we see now in retrospect as we look back over 3 years, our most successful implementers were sites that had active teams. They were sites that had buy-in from key leadership, but weren't necessarily driven by leadership. They were sites that had representation across disciplines and clinical flow, so they didn't have all medical side. They also had behavioral health side. They also had people from the front desk. They had people from depending how big the organization was, if they had data management people or IT people, they were involved from the get-go, right from the start, and that they had regularly scheduled meetings and that they made decisions at meetings that became the decisions. They didn't have a conversation in the room that was then different when they took it to the boss. And we found those to really be the most successful sites. Now, sites that didn't necessarily have teams or didn't have strong teams, it's not because they didn't necessarily endeavor to. Some of them didn't, perhaps because they were small or they didn't see the necessity of it. But some sites had turnover upon turnover upon turnover, turnover in leadership, turnover in champion, turnover in virtually every clinical staff person, and so they were starting over on a very regular basis, which made it really hard for them to have a team and to move forward with successful implementation. It also, however, underscores our train, and train again mantra. We have sites that have incorporated SBIRT implementation, the flow, the screens, the decision-making tree, all of the rest of it into their integration for all new staff. Because it's the only way they can possibly make sure that folks are going to really understand what this is about. We also see that successful sites invited and incorporated all of their team into all of the training that was offered, even if it was stuff that those staff weren't going to be doing. For example, front desk staff or MA staff coming to the brief intervention trainings when they're not the people that are going to be doing brief interventions. But it helped them really understand the nature of what they're talking about when they're talking about this SBIRT thing, and really built champions and team cohesion and problem solving, because those are folks that are like, oh, well, no wonder you need an extra 5 minutes in your visit. We can figure out how to finagle that. And it really helped with ensuring that that they were well aware of everything that went into all of the rest of the decision making that the team was going to engage in. The other thing that we heard, along with referral to treatment as being a barrier for SBIRT implementation, which we addressed earlier, we have heard about confidentiality as being this big, huge problem, potentially, from some sites. It's been a large perceived barrier. You know, we can't do that because we can't even write it down, and we can't talk to anybody about it. And when in actuality, patient confidentiality can be managed quite well in a primary care setting to meet federal regulatory guidelines, if they even apply, to meet standards of care and best practices from, for example, American Academy of Pediatrics around allowing young patients the opportunity to speak confidentially with their providers, and marrying that with a need by providers to feel comfortable and confident with what they're keeping to themselves and what they're sharing with parents. And we have found through being able to provide sites with good information about the legal and regulatory issues, and being able to talk through with sites around where they want to land in terms of their standards of practice around confidentiality as an organization, that it really hasn't been the barrier that people thought it was going to be up front. We haven't seen that in practice, and we really don't even hear sites talking about it at all anymore. It doesn't come up as an issue, which is incredibly surprising, considering we probably spent the first at least year of this initiative talking about confidentiality every time we talk to anybody. And now we just don't even get questions about it anymore, and not just from the sites that are already well on their way to implementation, but from relatively new sites as well, because we're able to pass on the learning from the other sites, and once they understand that other places aren't really worried about it, it makes them a lot less worried about it too, which is very helpful. The flow decisions are incredibly important, and flow has to be considered just as confidentiality has to be considered throughout the entire process. The flow of how everything is going to work has to be considered throughout the entire process as well. And as decisions are getting made, for example, what screen are we going to use, and how are we going to deliver it, and who's going to deliver it, and then how are we going to transfer that to the record, and when is that going to happen, and who's going to do that, and then how is anybody going to know if it was positive or negative, and who's going to do that. All of these flow decisions can influence both what screening tool is picked and how it's administered. Conversely, if there's already a mechanism in place for what screening tool exists and how it's going to be administered, that's going to influence all of these flow decisions. And every single one of them has to be in the context of how are you going to allow for privacy for that young person, and this is where we really got confounded a lot around the difference between legal confidentiality and privacy for the patient. Privacy to be able to answer those questions without mom looking over their shoulder, or without feeling like you're going to tell on me. If I tell you anything, you're going to turn around and tell my mom that I smoked pot once. In order for young people to share with their healthcare provider, they have to understand what the parameters of that sharing is, and they've got to know it up front, and that's another flow decision. So this is just an example of a couple of the questions related to screening that people have to really think about as they're starting to make flow decisions. But as you can imagine, you could probably come up with about 20, and that's just about screening. Never mind then who, when, and how does brief intervention work, and then when, how, and who are you going to refer to treatment, and yeah, follow-up, that's all nice and good and everything, but how's that actually going to happen? Who's going to do it? And then even more importantly, how are we going to know that somebody needs to do it? I think I said before that we have found the primary care provider themselves is an ideal person to have that brief conversation. It really reinforces the notion that this is health behavior when the healthcare provider is the one that's talking to the young person about it. And it also sets an expectation that this is a conversation that can happen across the lifespan. And to my mind, one of the key outcomes from SBIRT implementation that I would like to be able to see in my lifetime is that folks are not in any way surprised if their healthcare provider asks them about alcohol and drugs, that it will just be normal because, you know, I have a 12-year-old, and if his healthcare provider starts asking him at the age of 12 and does so on until forever, at least once a year, it will be a thing, an issue that he will know is connected to his health. And should he ever start running into a problem related to alcohol and drug use, perhaps that is a person that he would tell about it. So we put up one example of site flow. There are some that are incredibly complex. This one is pretty straightforward, though it may still look a little complicated. It's color-coded by role, by person, so that they know who's supposed to be doing what. And it actually is fairly straightforward. And it doesn't loop back on itself because that would just be visually messy, but actually the follow-up and closing the circle is implied over and over again, and I'll walk you through a quick way that would happen. So, so annual screening. So I'm 15 and I come in for my well child check. The rooming staff would understand that I'm 15, so I will get the craft. My screen is positive, so my provider talks to me. I did not screen at a level that they're talking to me about a referral. So did I consent to a referral? No, because I didn't need one. So they recommend a follow-up appointment in a month because we had a conversation about reducing my weekend alcohol use, and that follow-up appointment is scheduled. So here's where the loop starts again, because what's going to happen at the follow-up appointment, we're going to continue that conversation with a more brief intervention and motivational language. We're going to go back to, does she need a referral? Does she consent to a referral? We're going to go back into yes or no, and maybe we're going to no again, and then we're going to think about what happens next, and we're going to keep going around. So that this is a loop over time. On the other hand, if I come in for my follow-up and I am no longer engaging in any drinking behavior, and then the natural closing of the loop would be when I come back in for my annual screen, and we have that process start over again. On the other hand, if the behavior is escalated and the provider is concerned about it and talks to me about a referral, which I accept, then the loop goes off in a different direction, and we're going into referral and the referral to the alcohol and drug counselor, who is going to do that assessment and treatment planning with me, and then it will go from there. So electronic health records can be helpful tools or can be the bane of the site's existence around this project, depending on what record they use, depending on their access and ability to influence changes in that record, and how accessible it can be in real time, all of the rest of this. Ideally, the electronic health record can be a handy brain that is a helpful tool to this process. So we do have sites whose patients answer screening questions on an electronic tablet in the waiting room. That information in real time is visible in their health record that the provider has open on their laptop when they open it up for that appointment. It pulls up an alert that says this kid was positive and for this, and then a recommendation around the brief intervention, and then actually a click button that asks them what did they do, and they've got choices of what did they do. And then is there a follow-up needed, and what's going to happen with that, so that all of that information goes in to the health record. Not only so it's recorded in the health record, which is the ethical thing to do around health information gathered from a patient, but also so that it can be counted and quantified and pulled out of the record and aggregated and reported up to people like us and the Charitable Foundation and Hilton Foundation. So there are sites who have had the capacity and have been able to use these grant funds to create those kinds of flows, which is the ideal. Of course, there are other sites whose EHR seems to more get in their way than help them, and winds up being an extra step. They screen, screen on paper, and then somebody has to take the time to go in and enter the screening results into the EHR, and then go to a separate place to enter them into the database of whatever they're keeping in order to keep the data that they need to be able to report it out to the funders, and it's a huge pain in the neck. So we certainly try very hard to support sites in integrating as many of the steps in whatever protocol they develop into their health record as they possibly can. And in ways that can be pulled out and aggregated, not in process notes like you see in this example, because you can't aggregate anything from that. This is a pulled example from the playbook of New Hampshire SBIRT billing and coding. We did a lot of work around determining how sites may and may not bill and code for screening, brief intervention, and referral to treatment activities. That is not just using SBIRT codes, though SBIRT codes are turned on in New Hampshire Medicaid. And this is an example, though I will say this is the traditional, what we call traditional Medicaid, which is billing directly to our New Hampshire Medicaid department. Very little of that happens anymore. We've moved to Medicaid managed care, and our Medicaid expansion population is actually in the commercial market. So there's very little so-called traditional Medicaid billing. Billing for SBIRT activities have to be done through coding with the MCOs or the commercial marketplace, and we've done a lot of work to help sites figure out what that looks like as well. I just threw this one up as an example, but in our playbook we have all of the New Hampshire specific information. It is different from state to state, and that is a helpful thing if you're going to implement SBIRT, to really understand how to recommend to practitioners to be able to bill. Just to reinforce train, train, and train again, we offer all kinds of training resources on demand, really, from sites, and individualized to the needs of that site. So if there's a particular audience or a particular setting, we individualize it to that. We don't just have some standard ones that we do. We modify them based on the site and the needs and the time that they have available. So let me tell you about our outcomes before we get to the end here. Our screening results, we've had, as you can see in that right-hand pyramid, about 16% of young people have needed brief intervention or screened as needing brief intervention or referral to treatment, which is actually a little less than what we thought it was going to be, but seems to be in the ballpark nationally. We think there's some explanations for why it's less, and one of our theories, which we think is a strong one, is that we have to remember that these are young people who are accessing primary care on a regular basis. And that in and of itself may say something about who they are, what their family supports are, et cetera, et cetera. It also likely means that this cohort skews younger, which is another reason that we wouldn't have use rates as high as we expected. So through March of 2017, we've screened over, our sites have screened over 13,000 young people, which is over 75% of their patients, but we'd love to see that percentage be even higher, and as would most of the sites. Some of them have extraordinary high numbers, you know, and they're in the 95% screened. So we think that's going to continue to improve over time, and in fact, in this last quarter from January to March of 17, that percent screened was 81%. So we are seeing that improve, and we think that will continue to improve. We expect that number to be closer to 90% than to 80%. Positive screens, 2,000 kids, 16%. How many of them actually received brief intervention? 7%. That's 7% of screened. And only 5% of those screened needed a referral. Now you'll see there's a differential between needing a referral and actually referred, which is at first glance concerning. Our understanding is that that actually a number of these kids are already have already been identified, may already be in care, or are already in the system in some way. So we think what this does is reinforce the fact that SBIRT really is not about the deepest end kids. It's really not about referral to treatment. What it's really about is interrupting what is potentially a progressive problem. It's reinforcing no use for the ones that aren't using, and it's interrupting early use by doing that brief intervention and having those conversations about alcohol and drugs in a healthcare setting. That has never happened before, so we're pretty excited about it. The other thing that we're really excited about is that we think in some ways this initiative has been a catalyst for a mini SBIRT explosion across the state of New Hampshire, which is pretty exciting. Again, not all because of this initiative, in great part because it was included in that strategic planning process. But because of this initiative, we have developed expertise and resources that is now being used by a host of other folks. Our Department of Health and Human Services, Bureau of Drug and Alcohol Services, and Bureau of Maternal and Child Health Services mandated that all of the community health centers in the state of New Hampshire implement SBIRT for adults. In our cohort, we were already working with some of them on youth SBIRT, and then began working with all of them on adult SBIRT. And through doing that, we were able to engage some of the ones who hadn't been on doing youth. It's like, if you're going to start at 18, why not start at 12? These are problems with an age of onset, which is typically in adolescence, so why are you going to start screening for them after the fact? Why not screen when you have a likelihood of being able to reinforce that non-use message? And we certainly have organizations that jumped in wholeheartedly and have a host of F2HCs that are screening age 12 and up, which is very exciting. We also, there's a SAMHSA grant in the state in which 5 institutions of higher education are training SBIRT to health profession students, which is very exciting. Our New Hampshire Juvenile Diversion Network proposed to the Department of Health and Human Services, Bureau of Drug and Alcohol Services, that they incorporate our youth SBIRT learning into the all 15 Juvenile Diversion Network programs, and they embarked on that this year with some great success already, which is very exciting. It was an opportunity for them to standardize screening, universal screening, to learn and implement motivational interviewing language in their conversations, to ensure that they had MOUs with assessment and treatment providers, and to standardize their protocols around referring to treatment, which was really exciting. And then even bigger than that is New Hampshire received a Medicaid 1115 waiver, which is engaging most primary care, hospitals, behavioral health, and human services organizations in the state around behavioral health integration, and that one of the core measures that they chose was screening for alcohol and other drugs and appropriate follow-up for all patient ages 12 and up. And we know that that was influenced directly by our initiative, and it has also lit a fire under sites that have previously been reticent, because now that they're going to be held accountable to that measure, they want to make sure they know how to do it. So they are reaching out around SBIRT implementation and training, which is really exciting. Just a quick visualization. Those are our youth sites, our adult sites, and the combination of the two. This is not including the new Medicaid waiver folks. These are the sites in our current youth cohort and in our F2HC work. And then finally, if people can stay on for just a couple minutes, we have a video to show you that really sums it all up. Dang it. Here we go. We can do it. Come on. It should hyperlink for me. Why is it not wanting to do that? Sorry, folks. Give me a sec. I've got it right here.
Good at immunizations, we're good at talking about diet and exercise, and we're good at a lot of different things. But talking about substance misuse was challenging, and figuring out how to bring it up and how to begin a conversation was an area I knew that we could do better in.
We're asking the question about substance use, but we weren't asking.
Come on. No. My apologies, that's not right. I don't know why it's doing this.
Well, Jenna,
No.
I see you 3
Yeah. All right, folks. Let me get back to where I was. Well, I'm sorry about that, but if you go to our website, sbirtnh.org, please click on the video. It's lovely, and there's a couple great vignettes from practitioners in there. So this is who we are, and with all that, I am going to stop talking and hope that maybe there's some questions.
Hi, Amy. Thank you so much. That was a really great presentation. And also, thank you for being so savvy with your workarounds and showing the actual site and if it didn't work in your PowerPoint. So throughout the webinar, there was one question that came in. And folks, if you have any questions, you can go ahead and type them up in the Q&A panel, or you can put them in the chat pane too. But I'll go ahead and read the one that came in. It was actually earlier on. So they were asking, have there been any follow-ups done via telehealth monitoring and secure Skype?
Not that I know of. Not that I know of, though I think that that is something that some of the sites are interested in. One of the things that has happened, as different organizations have gone to implement SBIRT and have been being thoughtful about privacy and being thoughtful about follow-up and been looking at flow, is a number of them have realized that their patient portal sites are not as secure as they would want them to be for their young people. And that, in fact, there was one of the organizations actually discontinued portals for their 13 to 17-year-old because what they knew was that only parents used those portals, even though only kids were supposed to get the access information, and that if they were documenting their brief intervention conversations in there and screening results in a way that would then be open for parents to see, that that would be going back on the privacy that they talked about with their patient. So we know one site actually diminished the use of that portal. We know another organization is looking at how to enhance the use of the portal to do exactly what you're talking about and to be able to chat with each other via the portal, back and forth, send messages to each other, but potentially also to be able to have some face-to-face telehealth communication instead of a phone call to check in. But no one's doing it that I know of.
Okay. So we have had more come in. The next one is, so since most BIs last less than 15 minutes, which types of billing codes do you recommend providers try to use?
Oh, that is the big kerfuffle right there. It's really a problem with defining SBIRT and with those federal SBIRT codes. So what we see in practice is that what's making more sense for sites is that they upcode the visit, that they code for a longer visit. They don't code specifically around an SBIRT activity. And they code for a longer visit because of, I think there's a code around behavioral health concern or something. I can't think what the word is, but there's one that definitely makes sense. I have my playbook right in front of me. I should look up my answers. Why try and do it off the top of my head?
Okay. You know, you could always, once you look it up, you could always send it to me, and I can be sure to send it out to the folks that had asked.
Okay.
Okay, let's see. Our next question is, how long did it take to have full implementation among the first 5 sites, and what were the lessons learned?
I have my colleague, Leah Lefebvre, here with me, who actually has been the director and driver of this project, though she makes me go out and be the voice. She's like, don't you dare say that, but it's true. And what would you say, Lee, a year at least for our first cohort to get up and running?
I would say like 12 to 16 months maybe.
Yeah.
But the second and third cohorts went up, were launched in a much quicker time frame because they had the benefit of the first cohort learning.
Yeah, and because we had the benefit of the first cohort learning, so we could really understand better ways to get them prepared and move them forward. One of the things we saw was that there was a couple of sites in the first cohort that really felt like they had to prepare for everything and anything before they could really launch, and that they had to train everybody and everything before they could really launch. So we had them on the one end, and then on the other end, we had a site that didn't train anybody in anything and kind of did a soft launch and then responded to the providers' inquiries around the changes in flow, and then their need around identifying need for training around BI, and rapidly responded and got us in there to do that. We thought those were extremes on both ends, and we had concerns about both of them, but frankly, in practice, the ones who just dove in without a net wound up getting more buy-in right off the get-go from their staff because it was the practitioners that were requesting the training. Whereas the folks on the other end, where they tried to prepare for everything up front, they ran up into all of the resistance from providers that they already knew how to do everything, which is a lot of what we hear. And so they weren't engaged in the training. They didn't pay attention to the flow changes. They didn't pay attention to any of it until they started doing it. And that was a site where we had to go back and do all of the same trainings all over again with almost the same people because the second time around they paid attention. So being able to learn and not be so tentative, I think, about implementation was a was a big learning, for sure.
And the playbook that's on the website right now is the second iteration, which incorporates, actually it incorporates 2 years, or two iterations of learning around implementation. So everything that we learned about what it's important for brief intervention in the practice setting is incorporated into the play.
Yeah, and then if this is still working, just as an example, so we do an overview of the play, our recommended approach, that's based on what we've seen work for sites, and then we do a little kind of keep in mind, which is our little poke like, remember, you got to be thinking about all of this stuff. And then to the extent that we've gathered examples or other ancillary information that they may want that we put in appendices, we've got connections to that as well. So for any given play, we've tried to summarize it on 1 or 2 pages, and it really hits the, here's the lessons learned, here's the things that we saw that worked.
All right, awesome, thank you. The next one is, how are families involved?
That's a great question, and it's really something that that several sites really were attentive to incorporating right from the get-go. So I think a couple of different ways. I will say up front, another hesitation or concern or something that folks thought they had to prepare for, more so in the first cohort than anywhere else, was, oh my gosh, how are we going to tell families that we're asking these questions? How are we going to tell families that we're asking these questions and we're not necessarily going to tell them the answers? How are we going to, right? And yet we still want to engage them. You know, families are our key to, are a key resource for young people that are having problems. They're also a key to prevention for young people who are not using, or for changing behavior for young people that might be having some problematic use but haven't developed substance use disorders. So all of that is to say that sites have incorporated information into their waiting rooms. They've incorporated informational sheets for the parents, information around good alcohol and drug information, adolescent brain development, all that kind of stuff, and also prevention messaging kind of stuff that some of them have for parents to read while the young person is doing the screen, because it not only does it keep the parent busy, but it also provides them with some really good info that they may not have. In terms of engaging families around kids who may be using or who there are potential concerns about, that was another area where it was really anticipated that that was going to be a hard thing to do. How are we going to, number one, convince kids that we should talk to their parents about this? And how are we, number two, going to deal with these parents who are going to be all upset with us for asking these questions or for bringing up this topic? Were both things that sites were anticipating having problems with, problems which we never ever saw. We have not heard about at all in practice. And that was our understanding, and it was our understanding, you know, nationally from talking to other people and other implementers is that that's typically not the case. So one of our lessons learned that we train to now is to really practitioners to have that, when they're having that conversation where they have a concern with their young patient, to ask their patient, can we talk to your parents about this? Is this something that you think your parents already know about? Have you talked to your parents about this? And, you know, what we're understanding is the vast, vast majority of the time, it is something that parents are already aware of. So it's not a surprise to parents. It may be the first time they're having an out loud conversation about it, but most kids say, oh yeah, my parents know, or my parents must know, or my mom's the one that caught me, or my mom, you know, or whatever the case may be. I got suspended. Yeah, they know. So it's not kind of the difficult, secret kind of disclosure that folks think it's going to be up front. And then engaging families around family support. We do have a burgeoning network of family support groups in the state of New Hampshire, and we've also made sure that provider sites have that information and that that's readily available to families. Because parents who have a child who's struggling with a substance use disorder also need help. It's a very difficult thing to deal with. So we want to make sure they have access to that as well. Did that answer the question?
Yeah, I think so. I think that was great. And the last one we have here are, what are the demographics of the youth participants?
That is a really good question. Well,
it just varies.
Yeah, it varies very much from site to site. New Hampshire is an overwhelmingly Caucasian state, but we do, and particularly in our rural areas, we do have some more diversity in our more urban areas, though sometimes people giggle at what we think of as urban. Our largest city has 115,000 people. So it depends from region to region. It also depends by the nature of the practice. Our FQHCs have more diverse, more ethnic and racial diversity than our other practice sites. And they also have more socioeconomic diversity, though again that ranges over the state because the socioeconomic status ranges quite dramatically over our state, from rural to urban, which is top to bottom in New Hampshire. It's kind of we're kind of a triangle, and the top 2/3 of the triangle is more rural, far less developed, and has lower socioeconomic status and higher use rates of alcohol and other drugs.
All right, thank you. And I just wanted to let everybody know that if you, for some reason you have some other questions that come up, you can always email them to me. The email address is info@ireta.org, and then I can be sure that I share them with you, Amy, and we can get the answers back to everybody. So that was all the questions that we had. I did get a few people that gave you a little bit of feedback, so I'll just share it with you. One of them said that one of their local hospital systems is using secure Skype on iPads for mental health interventions, but for adults.
That's great.
Yeah, that's awesome.
That's exciting.
Also, the gentleman who had asked about the codes, he said he's looking forward to hearing, since it's something a lot of folks seem to want to know. So if you have time later today or within the next couple of days, you can send them over to me, and then I can make sure that everybody that was on the webinar today gets that information.
Yeah, we can send you our appendix that we developed around billing and coding. So it has New Hampshire specific information, but of course there's a national, I mean, then the work is to understand if these are codes that their Medicaid reimburses in their state and if their private insurance contracts will reimburse around these codes.
Okay.
But we can send you what we've got.
Yeah, that would be great.
It's like 4 pages, a 4-page summary of what we know about billing and coding.
Yeah, okay, great. All right, well, I want to thank everybody for your questions and participation, and thank you again, Amy, for such a great webinar. At this time, I just wanted to go over our evaluation and CEU instructions. So you'll receive a few emails from us following this webinar. Included in one of the emails is going to be a link to our evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance, or NADAC, or PCB CEUs. Should you choose to skip the evaluation and proceed directly to the CEU request, leave all the answers blank on the evaluation. And due to our migration to WebEx, your attendance cannot be verified until 48 hours after the webinar. So this means your certificates of attendance and continuing education will not be available for download until Monday, May 29th, although you will be able to request your certificates once you get the email immediately following the webinar. Again, we want to thank everybody for their participation today, and if you have any questions, please feel free to reach out to us at info@ireta.org. Thanks again, everybody. Have a great day.
Thank you.